what ended up happening is he just got overly sedated where he had to be intubated. He had to get trached for these withdrawals. And there was this one episode where he was bleeding out of his trach. I don't know what he did, where an ENT doctor had to emergently come in and cauterize a vein because there was just so much blood. So yeah, alcohol withdrawals aren't fun.
Oh, I gotta go. I've been working, told them please don't hit my phone. I'm in my zone, bruh, just leave me alone. Was on the road, but I swear I'm coming home. Now the drinks on me, I think we need a toast. See, I did it for me. Now my old friends calling, told them nothing's for free. Told me time is money, dog, swear I paid all my fees. I was starving for this game, now my family can eat.
Hey everyone, welcome to the Cup of Nurses show with your hosts Peter and Matt, two nurses on a mission to change this world with one conversation at a time. So let's jump right into it. If you find value in this show and want to join us on this mission, it would mean everything to us if you share and review the show. If you want to find out more about us, our show notes, check out cupofnurses.com for all the info, latest merch releases, and for our lifestyle podcast. You can check us out on wearefrontlinewarriors.com.
In this episode, we are going to talk about the CIWA protocol and how we manage alcohol withdrawal in the hospital. So when it comes to alcohol withdrawal and the CIWA protocol, first thing you have to do is take into consideration, where do these effects come from? Why do people have certain signs and symptoms when they go through alcohol withdrawal? So people that drink alcohol, they use ethanol. And ethanol stimulates the GABA receptors. So it acts as like a depressor, or you could say a more depressing neurotransmitter in the place of GABA. And what happens is it works the same way GABA does. And when you think about GABA, we mentioned neurotransmitters a few episodes ago, especially when we talked about like the central nervous system. So alcohol is a central nervous depressant, and GABA also works on the central nervous system. So they correlate. They work basically in a very similar fashion, where alcohol is a depressant, and in GABA receptors, when you activate GABA, it's also a depressant. What GABA essentially does is it slows down and stops certain transmissions and messages that go on in your brain. So it's the way your central nervous kind of winds down and it calms down, because remember, our brain is like a circuit. It's always getting inputs, it's always getting stimulated, and GABA, you could say in a sense, regulates that by silencing those messages that you don't really need right now.
Very good way of explaining it. And what happens, alcohol creates this homeostasis in the body. So over time, you become so dependent on it where you need ethanol, aka alcohol, to preserve this homeostasis. And what happens is it decreases these excitatory tones, whatever you want to call them, of the central nervous system, where you basically numb yourself, essentially. What happens. So you are in this numb state for such a long time where you don't drink alcohol, and after 6 hours you start getting into these withdrawals, and then bam, everything goes crazy and haywire because your central nervous system is in complete fight or flight, going crazy trying to restore balance. And this is when these patients come into us. We have to treat them. And let me tell you guys, what I thought was withdrawal symptoms from the textbooks, it's a completely different story. The sundowners do not even compare when it comes to the crazy stuff that we saw with alcohol withdrawal patients. And I'm sure anybody listening could relate to that. They might have some crazy stories themselves. They might have got punched, swung at, spit at, looked at, talked bad to. These patients are the nastiest that you can have in a hospital.
Yeah, it's very dangerous. People could go into a coma and die from that. It's crazy to think about. And it's very interesting that, so like we mentioned GABA, a little bit ago, and it's almost like the ethanol replaces these GABA receptors, you could say, and the function of GABA, and your body flips to now looking for those depressive effects in alcohol. So it's almost a flip-flop. That's why it's so dangerous when you abruptly stop drinking alcohol and you get these crazy signs and symptoms that Matt was talking about, because your body does not know how to calm down. Because before you became an alcoholic, or before your patient became, I guess you could say, an alcoholic or alcohol dependent, his body was focused on using GABA to slow everything down. And now with him drinking so much alcohol every day, it's almost like the alcohol is replacing the GABA, and that's what's causing them this depression, this relaxation, this calmness.
Yeah, and you bring up a good point, because honestly, alcohol dependency goes hand in hand with anxiety, and patients with anxiety have this overstimulated nervous system where they don't know how to regulate their emotions, their nervous system. And what do? They use drugs to do that. They could be smoking pot, they could be taking other substances. In this case, they're using alcohol to numb, and using GABA, which inhibits these messages that Peter talked about, where you don't have this influx of sensory input, where you feel calm, you feel relaxed. But the thing is, this is a band-aid approach. Just like with anything, you're not solving the real root issue. Is like, why you're having anxiety, why are you having this influx of emotions where you can't regulate them? You need to down them down with alcohol. And I think that's what's interesting too. When you have these patients, talk to them a little bit. They're going through hell right now. They're withdrawing. We're going to talk about CIWA and everything they're doing, and you can just do the medical management side of things and push Ativan and stuff, but find out on an emotional level what's going on in their life. Why did they hit rock bottom? Why are they drinking a fifth of alcohol or 6 beers or 3 glasses of wine that's putting them in this mental state? And you might find some interesting information, perspective exactly of why this person is doing what they're doing. And maybe you could be the little life coach during that time, or therapist, and you can help them out and give them some advice, because sometimes that could make or break it, where they could fight these withdrawals and feel better. Because why are they there to begin with? They were numbing something. What is it that they're numbing in their life that they're trying to escape from?
Yeah, I fully agree with you. Not every SWAT patient you have the ability to talk to and communicate, because they're going to be going through a lot. But it's a really, really interesting experience when somebody tells you why they drink, what happened in life that caused them to drink, and how much they drink. Because sometimes we can't really comprehend why people choose alcohol to, you could say, balance out their feelings, because we can't always see ourselves in that person's shoes. It's really hard. But then when you really dig deep, like Matt said, and find the root cause of this, usually times it's very sad. They're usually missing love in their life. They're not satisfied with where they are in life, and they just don't know how to fix it. And their solution to kind of fixing it is to numbing it. So they're avoiding those feelings, and they're avoiding trying to find a solution, because alcohol it's not a solution. It's not gonna give you that love. It's not gonna make you feel any better. It's just a way for you to get away from reality.
Yeah, and that's really tough, because looking at that dynamic, if they feel lonely or they don't love themselves, they don't feel love from other people, and they drink to do that, where usually we see them where their family left them and they went really bad into the spell of drinking, and they cranked up their tolerance, or their family left them, or they dropped them off to the ER in this case. And yeah, it's just bad, man. And with these patients, not to get all psychological and stuff, but the families need to create a safe space for them, or love them and be patient with them. And that's really hard to do when years and years go on and they do the same stuff over and over again. And, this kind of hits home, because Peter and I are from a Polish household where our fathers liked to drink a lot in the past, and it's the same shit all over again. It's really hard to tell them, to be honest, hey, like, this is bad for you, don't do it. Or loved ones that are close and relatives, they just indulge in this. You can't tell them anything. They know better. And sometimes you just have to love them from a distance, accept them for who they are, not try to change them, and let them explore their own rock bottom, and hopefully that will help them change, man.
Yeah, hopefully, because change comes within. You could pray for somebody, help somebody as much as you can. You can spend hours, 24 hours a day with them, but that change has to be internal, has to come within. You can't fix them. They have to be able to open up and fix themselves. So going into the alcohol withdrawal sign and symptoms, a little bit of the timeline. Usually the milder symptoms start within 6 hours after their first drink, which is interesting, because sometimes people come into the ER and you ask them when their last drink was, and like an hour ago.
You remember you told me that patient that he was nervous to come into the hospital, so he drank alcohol before he checked himself in.
Yeah, and you hear that kind of stuff, so you're like, okay, well, this patient's gonna first of all have to sober up, and after they sober up, they're gonna slowly start getting these mild withdrawal symptoms. So you maybe have like 6 to 12 hours of having a decently stable patient before things start acting up, or they start acting up, or they start feeling nauseous. They may feel anxious, have a little bit of tremors, some vomiting, insomnia, sweating, headache, something mild that people It's almost like a hangover in a sense, but a little bit more of a, you could say, a sensory overload kind of thing.
Yeah. And that's what's happening. The GABA is not binding to the central nervous system, wherever it was inhibiting these neurotransmitters from slowing down, and now you're experiencing these symptoms. And if you want to go more in depth with the gamma receptors and the neurotransmitters, you could check up our show notes on couplenurses.com on episode 188. I think it'd be very boring if Peter and I just read off what is gamma aminobutyric acid to you guys and do all that. So if you want to dig deeper into alcohol withdrawal, just check out our show notes. We have a ton of information there.
Yeah. And then you're going to see the harsher and the hardest symptoms anywhere between 48 hours to 72 hours after their last drink. So when you're at this point, patient's probably been at hospital maybe a day or two. So you're going to be like, okay, this patient was calm, but now it's already like day two and a half. Now you might see some of the iffier stuff, the scarier stuff that goes on with alcohol withdrawal, especially if they drink like a gallon a day. Some people drink up to a gallon a day. So the more you drink, the harsher these withdrawal symptoms are going to be. So some of the crazy stuff you might see anywhere from 48, 72 hours after the last drink. You might see seizures, hallucinations. Those could be visual hallucinations, auditory hallucinations, racing heart, very big tremors. They might get delirious, real sweaty. A lot of times when people are going through a hard withdrawal, they're really, really sweaty. They're sleeping because maybe you give them some Ativan. They're sleeping, but they're sweating and they're going through. They feel hot. Might have a fever. Their hands might be swollen. They might have like these little neuropathic pains, hypertensive. Those are like your serious alcohol withdrawals. And of course, if they have a seizure, that's basically as serious as it gets, because they could pinch off their airway, not be able to breathe. They could hurt themselves while they're seizing. They could vomit, aspirate. So you want to really pay attention to that. And a lot of our nursing management and care is to prevent those seizures. We're going to talk a little bit later about the medications. And one of the main focus on these medications is to decrease the stimulation and activity in your brain to prevent this high heart rate, these tremors, this nausea, this vomiting, and of course, prevent that seizure. Because once that seizure comes, it's usually a clonic-tonic seizure, and it's one of the worst seizures that you're going to see and experience, because they're literally, like almost shaking. The tonic-clonic seizure, if you guys ever seen tonic-clonic seizure, that's like the worst and most visual seizure you could have, and it's very scary. So you want to prevent them from hitting that point, and they could go into coma, they could die. A lot of things could go south after they hit that seizure.
Yeah, one time I had a patient that was in E2H withdrawals, but dude just wanted more Ativan, and we knew that he was just fine, so he faked his own seizure, and I had to call rapid response. And I still pushed that milligram, and it was just a weird scene where the supervisor is like, okay, you're not having a real seizure, you're faking it, because I forget what we used to assess that, but we knew that he wasn't really seizing based on him. But yeah, anyways, these alcoholic patients are characters. So we're going to go into CIWA protocol and actually what it is. So CIWA protocol, you might have heard it in nursing school. You have to chart on it every 4 hours, or depending on when you give your pushes of Ativan for these withdrawal patients. So it's called the Clinical Institute Withdrawal Assessment Alcohol Scale Revised, and is an instrument by medical professionals such as nurses to assess and diagnose the severity of their alcohol withdrawal. So it starts from a scale of 0. I think it goes up all the way to like 67 or something, really high score. But anything above 20, you're considered to have serious withdrawals. And we're going to give you Ativan based on that scale. So it's very helpful. It's very simple. You don't have to call doctors. It's just using your own critical thinking skills to diagnose how much Ativan the patient is going to need. And depending on how bad of a drinker the patient is, that's when you'll find out how much Ativan you're going to give, right? And it sounds scary at first, because sometimes you're pushing like 4 milligrams, 6 milligrams. You're like, whoa, I give a milligram or two to an old lady or a patient, and they're like snowed and knocked out and uncomfortable. One thing you have to realize with alcohol dependency is there's a tolerance that builds up, right? How come that person needs to drink a gallon, not a drink or two like some normal people, to feel the same effects of alcohol? Well, they overstimulated their central nervous system. They need more of that gamma or GABA, and it requires a lot more alcohol. So therefore, the scale is going to depend on the severity of how much Ativan you're giving, if that makes sense. So don't feel scared to push to 4 and 6 if the person is in real withdrawals. You're not gonna kill them in this case. At least I hope not. You know what I'm saying? Use your nursing judgment. Don't quote me on this one, where I'm saying 6 milligrams won't do anything and then something happens. So, maybe you're going to give the patient some oxygen or something, or give them on a capnography, end-tidal CO2 if it gets more severe. So I think that depends on hospital protocol too, because in this place I noticed no one really does that for ETOH withdrawals, but I know when they get a PCA, like a morphine push pump, for those that know what PCA means, sometimes those patients go on the end-tidal CO2. So
yeah, and I want to recommend, given if you're going to push Ativan and stuff, do it IV. I feel like sometimes if you give it to them PO, I know they could swallow, and of course that's like, you could say, the best route of administering medication. It's PO. We always talk about that in nursing school. If you could give PO, give PO. But sometimes the PO takes a little bit longer to start working, and what sometimes happens is you're given Ativan every like 15, half an hour. So you give them, to say, 4 milligrams PO, and then you got to give them again 4 milligrams PO 15 minutes later. But remember, PO takes a little bit longer to kick in. So sometimes you might overload them, and you might give them 4. Now, 15 minutes again, you might give them another 4. So you give them 8, and then you give them another IV because it's not working, and you give them another 4 IV. So it's 4, 8, 12 milligrams. And then an hour later, your patient is basically super snowed or going apneic because you kind of overloaded them. So I always say give the Ativan IV because it works the quickest, and it's better to gauge. Sometimes it's a little bit shorter lasting given IV, but remember, when they're scoring really high on the CIWA protocol, you could give them medication every 15 minutes. You give it fairly early. You don't have to wait the hour or 2 hours because this is a protocol. So it gives you parameters on when to push what and how long you should wait. So always try to go the IV route. It works quicker, doesn't last as long, but it's better than overloading the patient and have them go into respiratory depression an hour or 2 hours later because you kind of overloaded them.
Yeah, very good point. Plus, every patient has different absorption rates and the way their metabolic body breaks things down. So giving IV is completely straight into the bloodstream, and you can gauge that patient how they're doing in real time.
Yeah, and also put in 2 IVs just in case one blows. You don't want to have a CIWA patient with just 1 IV, because if they're scoring high on a severe scale and they're not compliant or giving you a hard time, then a 1 IV comes out. You're not going to give them PO then when they're going through hallucinations, auditory, visual. It's going to be hard to calm them down. So make sure you get 2 IVs, because if one blows, at least you have that second one, because you're going to definitely have to give them IV Ativan if they're going through severe withdrawals.
Yeah. So we're just going to go down through the actual CIWA protocol scale, and this will kind of give you a refresher of the symptoms your patient might have. So it's very simple. I think it takes like 2 minutes. Perfect process, and you actually just click through it on most computers, and it's nice because there's a chart in Epic mostly. I don't know if Meditech does it. I know Cerner and Epic does have it where you see the scale on what's going on with the patient and how to score them. So first one is nausea and vomiting. It is a withdrawal symptom. They're going to have scale them on how they're feeling from 0 to 7. The other one is agitation. Usually their nervous system is all routed up and aroused, so they're going to be agitated. They might be restless. They might be kind of thrashed around the bed, trying to get out of bed. So you're going to gauge that agitation based on assessment like that. The third one is going to be visual disturbances, and this is going to be your hallucinations. You're going to ask them if they see anything. Sometimes, based on how crazy the withdrawals are, you're going to be in the room and they're going to be already talking crazy. And if the wall's moving, or they're telling somebody to get out of the room, or talking to kids or some crazy stuff, they're seeing some stuff. So you could rate them on hallucinations based on that. How much is there? There's 10, so I'll do 5. The fourth one is going to be tremors. Most you can see that in their fingertips, so they could just hold their hands out and see how they're shaking and go from there and base that scale there. Tactile disturbances. How is their sensations? A lot of them might feel like pins or needles, maybe some itching. They're itching all around. They feel like some burning sensations. So base that off that.
Or they might feel like someone's trying to kill them,
Yes.
or like stabbing them in their arms. It's almost like you could also have these tactile disturbances where it's a hallucination, where people feel like there's a knife going through their arms or someone's cutting them. It'd be really messed up like that. Number 6, headache, fullness in the head. That's self-explanatory. See how bad the headache is. Ask them to rate it 0 to 7. And if they say 7, they're probably having an extreme severe headache. Proximal sweats. Usually you can see that best on like their face, their forehead, or you touch their gown and it's like completely wet. You're like, hey, did you pee your bed? Like, no, I'm just sweating out and I'm warm. So make sure you change your gown. You're just uncomfortable being in a sweaty gown. Imagine being in wet clothes for 12 hours. It sucks. So make sure you guys do that. Auditory disturbances, very similar to hallucinations, but in a sense of they're hearing stuff. They could be like, hey, they might be like, hey, did you hear that? Yeah, my mom just told me this, and they'll repeat what their mom said, but their mom's not really there, so they're hearing stuff. And sometimes this could be also in their sleep. For example, when they were awake, they were hallucinating, but when they fall asleep, they were just hallucinating kind of in their dreams. They were hearing stuff, they're having a conversation. So I rated them higher up because they were having some audio disturbances because they were hearing someone talking to them and they were answering those questions. Number 9 is going to be orientation and a clouding of the sensorium. So make sure you're oriented. Ask them, where are they? What day it is? Do they know their name, first name? And if they're off by a lot or they're disoriented, rate them higher on the scale. And number 10 is the anxiety. So the highest rating is a 7 on this one as well. And that's like full-blown panic attack. Breathing, freaking out for no reason.
It's like they're schizo.
Yeah, literally like they're schizo. They're just severe anxiety. So make sure you also score that one as well. Just real quick, back to number 9, the orientation and clouding of sensorium. That's actually 0 out of 4, not 0 out of 7. That's all the other ones are 0 out of 7, but the number 9 orientation is going to be 0 out of 4. And like Matt said in the beginning, add those numbers together. It goes up to like the max is like 67 or something like that. And if you're less than 10, it's very mild. 10 to 15 is mild. 16 to 20 is moderate withdrawal, and of course anything above 20 is severe withdrawal.
Normally with these assessments, you're going to ask the patient these signs and symptoms, but in the real life scenario, your patient might be withdrawing. There might be their own little world, aka like a K-hole or something. So you're going to be using your best clinical judgment to rate them based on their severity. You're going to get the score on the computer, and based on that, you're going to know the drug dosages. So if you are scaling 5 to 9, you might have Ativan given 1 milligram every 4 hours. If you're 10 to 14, you might be giving lorazepam, aka Ativan, 2 milligrams Q2. If it's 15 to 19, which is the moderate symptoms, you're going to be giving it 3 milligrams Q1. And if it's 20 to 24 and above, you might be going anywhere from 4 milligrams every 13 minutes up to 6 milligrams every 10 minutes to drop that score down and have them be comfortable. One, it's for patient safety, and then 2, we're trying to prevent these seizures that these patients could have because they're so aroused by the central nervous system.
Yeah, you could also possibly even put them on a Ativan drip. It's not very common, but when it's requiring, for example, going through severe withdrawals and you're giving them, let's just say 6 milligrams every half an hour, that's a lot. You might be better off just putting them on a drip where they're constantly getting 1 milligram continuously or 2 milligrams continuously to their bloodstream.
Yeah.
I've only given Ativan drip one time, and when day shift came on, the physician came on, he freaked out because he never seen an Ativan drip and he automatically discontinued it. So I had him on Ativan drip for like 4 hours overnight, and he was super calm. And then they had a hard time with him during the day, so they put him back on. But as soon as like the doctor came and doing the rounds, he like freaked out. He was like, turn it off, put it back on protocol. But it worked.
Yeah, same thing here. I think I had 1 or 2 patients that were on an Ativan drip, and I remember he was a young guy in his 30s. What ended up happening is he just got overly sedated where he had to be intubated. He had to get trached for these withdrawals. And there was this one episode where he was bleeding out of his trach. I don't know what he did, where an ENT doctor had to emergently come in and cauterize a vein because there was just so much blood. So yeah, alcohol withdrawals aren't fun.
Not fun at all.
And of course, seizure precautions is something you should be worrying about. So what do you do for seizure precautions? One, of course, is always pad those side rails, use those briefs or tape, wrap it around, make sure the padding's good, reduce environmental stimuli, maybe turn off the lights, close the door if you can, do things that don't stimulate the person so much, put the patient in low bed position because he's a fall risk, and just have some oxygen set up bedside and a suction canister available just in case if he were to seize, you're going to turn him to the side, suction his mouth if he gets frothy and all that, extreme cases.
And then when it comes to drugs of choices, you mentioned lorazepam. That's Ativan. It's our first go-to. Medical management is going to be focused on benzodiazepines. So your most common ones are going to be the Ativan, Valium, and we also give Librium as well to help with all those withdrawals. And the way benzodiazepines work is they're a sedative. They work on your GABA, so they increase the effects of GABA. So it helps your body almost switch from the ethanol depression it's used to the depression using GABA. So you're trying to return your body back into homeostasis, how it's supposed to function, and not using alcohol to depress its stimulatory system and its CNS. It's flipping back to GABA. So benzodiazepines, you're gonna get sedation, you're gonna get relaxation. They might feel sleepy, reduces your anxiety, and also relaxes your muscles. So it's a really big calming effect. When it works very well. You're gonna see your patient go from hallucinations, being fidgety, moving around, to just calm, relaxed, and they're mostly going to fall asleep. That's why Matt mentioned the capnography, because some of them might have a little bit of apnea going on. A lot of our patients they have OSA, obstructive sleep apnea, so this is going to trigger more of it. And even for our patients that don't have apnea, this still might lead to decreased respiratory rate and I don't want to say cessation of breathing, because that's going to be
it depresses your drive to breathe.
Yeah,
like
so you
morphine.
might see that. Yeah, but usually they pass out right away and they're just sleeping the rest of the shift. You'd rather have them be sleeping versus them being awake, because you don't want them to go into the seizures. And if they're sleeping, it means they're not getting a lot of stimulation, and they're most likely not going to have those seizures.
Yeah, and then if you have patients that are in the ICU, or even before the ICU, if you have patients on the floor that are having extreme ETOH withdrawals, or they need closer monitoring, or they might need a Precedex drip, call a rapid, send them over our way to the ICU. We will take care of them. One drug we like to use is called Precedex, dexmethadone, if I'm pronouncing that right. So that's an adjunct that we give on Ativan. And I think there was like a study that I read before that they were able to decrease the use of benzos by like 60+% if you're using Precedex. So it's another sedative that we use, and it helps tremendously with sedatives. It honestly just puts them to sleep. Most patients, it puts them to sleep. They might be kind of really loopy, they don't know where they're at, but it almost puts them in a conscious coma, we like to call it, where they could fight off those crazy ETOH withdrawals from the 48 to 72 mark, and then we'll titrate the drip off. They feel dandy, and then they kind of get downgraded to a different floor. When it comes to Precedex, one thing you have to be careful if they have like a second degree AV block, because you might develop a abnormal heart rate. Sometimes it does slow their heart rate down, so they got juiced up on benzos, and now you're giving Precedex. They might be very brady. Depending on how you're titrating the drip, I think you start at like 0.2 mics per kg per minute. Some physicians like to do a loading dose for Precedex, just like you're doing Dilantin or other things, or amio. And if not, then you just start the drip and you just titrate by 0.2. Some places have different maxes. I know in Chicago we were doing 1.5 mics, and I know here now in this hospital they finally titrated up from 1.4 to 1.5. So the nurses here are happy because they could use that more of a higher dosage to snow the patient. And the last thing is just a lower blood pressure. So of course you're depressing the patient. They might be a little bit brady. They might be a little bit hypotensive depending on what's happening. So in the ICU we titrate drugs based on that. And then this is not a drug, but you might put them on restraints. If they're a safety risk, we put them in a 2-point restraints. Sometimes we use the vest. Sometimes we use the wrists. And I think the craziest patient I ever had, which is actually in this hospital in 2019, this guy was going in such crazy withdrawals where they put him in leather restraints. Security guard was there. We tried to, I think we ended up intubating the guy because they couldn't control him. Yeah. So those are the extremes where you put 4-point restraints. But hopefully we use all these other interventions that we don't have to restrain the person like they're in a freaking, like a torture show or something. Yeah. That one new show that everybody's watching on Netflix. I don't even know what it's called.
It's a torture show?
It's not a torture show, but it's like the criminal guy.
Dexter?
Nah, man. It's like all the women are about it. I just don't know what it's called. But what happened?
The one with that one serial killer, right?
Yeah,
Jeffrey Dahmer thing.
That guy.
Yeah.
By the way, eBay banned buying that costume off their website.
Why?
Because they have a policy. Anybody that like committed a crime or any violent crimes, you can't purchase anything to do with them within the 100 years.
Respect them.
Which makes sense, right? Because then people could get bad thoughts there. So
yeah, think about it. Like this psychopath, it's crazy because everyone knows about Jeffrey Dahmer, but they don't know something more important in life. Like, why are we, you could say putting this serial killer on a pedestal.
What's Pangea?
Right? Yeah, what is Pangea? You guys know?
From a Lil Dicky video.
Fuck with the war? Yeah. But thank you guys for tuning in. Hope you all learned something worth our episode on CIWA protocol and how we manage alcohol withdrawal in the patient. If you guys want to learn more or read a little bit more in depth of what we talked about, GABA, the whole protocol, we have all the information on our show notes. A lot more in depth than what we discussed right now. A lot of good information. But if you have any questions about anything, let us know or reach out to your educator. Some of these protocols are a little bit different, but I feel like we got the main gist of it, and you could probably pass your exam with this information.
Exactly. And if you like the show, please, guys, share with your loved ones, subscribe, give it a like. It means everything to us. It benefits us so much, and we continuously growing. And if you have some recs on what we should record next, hit us up in a DM, and see you on the next one.
See you guys next week. Bye-bye.